how can we support patients to feel more confident and attractive in their body? This is a patient saying, I don't feel very attractive or confident in my body anymore. How can I overcome this? And how can we support that kind of intimacy, of that fragility that sometimes carers have for their loved one who's been unwell, that they're so anxious that they don't want to touch them just in case they set off the ventilator, or just in case it affects their breathing, or just in case, in my case, in our patient group, oh my God, she'll have another heart attack, or she'll have another stroke, or whatever.
The partner doesn't want to break them.
Absolutely. Absolutely. And having that conversation can be challenging. Charlie or Nick, have you got any top tips?
I was just going to say, it is all about that communication, isn't it? And it doesn't have to be a verbal communication. It's kind of just saying, you know, if I touch your hand twice, that means I just need to slow down or have a pause, or that eye contact. I don't always think it has to be verbal communication in that moment. And it's just having that conversation beforehand. And there are things that your team can do, and then probably Nick will go through it, but you know, we can add bigger parameters so the alarms aren't going off if, you know, if the respiratory rate's going up or anything like that. So again, just giving confidence that the ventilator is there as an enabler. It's not a barrier, and that is the biggest thing. And I think we just have to, it's all about education and communication, I think.
The patient, before they were on the ventilator, wasn't feeling as well as this, you know, so it's a case of building on the improvement.
Yeah, that's exactly right, Chris. The idea of the ventilator is about trying to improve quality of life and energy and stuff. So I guess it comes to what everybody said, is actually having for a ventilation team or a physio team or a care team to be able to try and facilitate more intimacy. There need to be conversations, don't there? So people have to say, this is kind of what I'm thinking, this is maybe what I'm wanting, I don't know, but how could we explore this? Is there anything you could do? And yes, we can do things with ventilators, tubing, mask interfaces. There are some other things to think about. You know, ventilators are put on patients with all manner of different conditions, and it might be if you for example have COPD or something like that, having your inhalers close by so that you can take a puff of your inhaler before or mid intimacy. Some patients are ventilator dependent, and so will need to have their ventilator on, but some might not need to have their ventilator on, but could have it close by for a few breaths if they got too out of breath and their respiratory rate became uncomfortable. Sometimes holding the ventilator, not strapping it onto the face, just holding it, can be a helpful way of slowing down their respiratory rate. So things about oxygen, I guess a couple of things about oxygen. One is that it's safe to use during sex, and whether you're a long-term oxygen user or maybe an ambulatory oxygen user, somebody who uses oxygen when they're undertaking physical activity, that's both of those are safe to use during sex. The only thing I would say about that is, and it goes back to what Trudy was saying about lubricants, paraffin-based lubricants shouldn't be used in patients who are oxygen users. You should use water-based lubricants, just because paraffin is so flammable. So we always say to anybody who's using oxygen, don't use paraffin-based. You know, whether it's Vaseline on their lips for chapped lips or whether it's a lubricant, avoid that. And there are things as well, and Chris probably has done this thousands of times through his career, but actually things like talking to GPs about things like Viagra or that can be helpful for kind of maintaining erections and kind of improving sex. So I think those are my main kind of additional points I'd say there.
I think it's also really important to say that sex isn't just about penetration and about erections. It's about everything else that is around that. And I know Trudy and we've spoken a lot about this previously, haven't we? I wanted to ask one of the specific questions that was the patient is talking about here is, I don't feel very attractive or confident in my body anymore. How can we help patients have conversations? How can we support them with conversations with their partner about how their body may have changed, how they look different and they're going to feel different? How can we have those conversations or support patients and loved ones to have those conversations?
I think for when I've worked with patients in this scenario in my clinic, is that either I've gone out and done a home visit or they've come to the clinic themselves and brought the portable ventilator with them, is that they will say, talk a lot about not using their nice things anymore, or not wearing their, just for an example, nice underwear anymore, because they don't go very far, they're not really going out. What's the point of putting a bit of makeup on, or a bit of perfume, or aftershave, or whatever it might be? So it's sort of how they feel as well. And I think at some point along the way, as Chris said, as they start to feel better and start to feel sexual, it's about reclaiming your sexuality. So, you know, in the with the ability that I've got, what kind of sexual person do I want to be? How will that person behave? What would they enjoy? And sort of try and get a visual on what is possible. So for me as the therapist, I will take them step by step of what is okay, what do they fear, what might work, what code they could use. Is it a squeeze of a hand to stop? Is it you know, kind of holding on to somebody in a different way that says, I just want to stay with a cuddle for now? So those little messages, doing it in different ways rather than it be heard as a negative. So I will encourage patients to use the nice things and wear the nice things. And, you know, the products for some people mean a lot, you know, so even if you're not going out, put a bit of lip gloss on if you're able to use a product like that, or a little bit of perfume, as long as it's near a ventilator that you know is not going to cause any issue. Even just wearing your nice underwear, people feel better. It's that, you know, from inside, what can we do that makes us feel more like a sexual person or more attractive to our other person? There are some things we will just have to accept that we can't change, but how can we adapt it or embrace it or do something different with it? You know, I think that's the important thing.
The patient journey, one, to find out that you are available to help, and two, to get to your door is huge, isn't it? You know,
Yeah.
to actually admit there's a problem, talk to somebody, and then find out there's an outlet. A problem shared is a problem halved, is the old thing.
Right.
And nothing's changed. You know, the more we talk about it, the better we are. Us Brits have got to learn to give it more of that.
Absolutely. I mean, I am fortunate because I work in it's a private clinic, but I have contracts with the NHS. So the doctors are aware of me, they can refer in, the hospital departments know about me. And there are services, not as many as there should be, but across the country within the NHS. There are low-cost therapy available. You know, most therapists will hold 1, 2, maybe up to 6 spaces, pro bono sessions for situations like this. I know I certainly do. The students in training are always looking for placements, so it would be free to see. And, you know, we've all been students. And, you know, my opinion is, certainly the students I pick, is that they go all out to be the best that they possibly can. They cut a lot less corners, they put a lot more effort in. So I'd be snatching the hand off of a student in the right setting to be able to work with patients like this as well. So even if there isn't an NHS service where people are, there is something called, I'm sure you'll know about it, Chris, being a GP, is the individual funding request. Mm-hmm. Now, this is available all the way across England, and a GP or a healthcare professional can put in an application. It's not a difficult form to fill in and say, we don't have the specialist service. Given the situation of this patient, they would need a specialist. Therefore, I'm requesting funding for them to be able to see within whichever private clinic that might be. And I've got to say, I've never had one turned down. So if they're
that's interesting. Is that a bit of a postcode lottery, or is that a general response that you know about?
Well, I get them from out of area, from where outside my NHS area. So it's, you know, I guess I only get the ones where it's been said yes to. But if you've got a good GP or a healthcare professional, you would argue that cause of saying, why would you know, why, you know, go back, appeal it find out. You know, sometimes as well, even just having leaflets that you give a patient at home that mentions intimacy in there, and to say at any point, here's a list of resources, but at any point you want to talk to your healthcare provider, they are more than happy. They've done some basic training. They're very, you know, they may not have all the answers, but they can go away and find out. So I encourage people, even if you don't work in a medical setting, you can create a virtual team. So get in touch, you know, with other services in the area where you are, see what's available, what's possible, and link up with people.
That's right. You've got a friend you don't know, but you might have got a friend who might know.
Absolutely, totally agree. There's
because I certainly didn't know that was available as a what do they call it? An extra contractual referral. It used to be called, I think. But that's very worthwhile knowing. Although it still takes a little bit of there'll be a little bit of reticence from the patient to actually go to the GP. A different relationship again, but again, the more we talk, the better it is.
Sometimes there might be possible for self-referral as well. So again, anything that the healthcare professional can find as in resources locally, pop that into a little packet that you give the patient, saying there's lots of leaflets in here. I don't want to bombard you, but the next time I come, if there's some that you want to go through, I'll go through them with you. Or, you know, it's being sex positive. You know, that's the most important thing, that we do that.
So talking about sex positive environments, what top tips have we got for clinicians or patients? So what top tips have we got for clinicians on the call or watching this to be able to support them to create an environment that's a sex positive environment? And what top tips have we got for patients about raising the question? Because I think I have patients. So I had a patient in clinic last week who was, you know, we were about 2 minutes in and he'd sat down and the first thing he talked about was impotence. Right. Well, the problem is I've got the two problems I've got to discuss with you, Kate, are this, and then the second one is impotence. And he's an exception. He was somebody who brought that to the clinic very, very quickly, but I don't think that's true of all of our patients. So what tips can we give our colleagues on the call to be able to support them creating a sex positive environment? And if you as a patient are coming to a clinic and you want to have a conversation about it, what top tips can we give to patients about introducing the topic if you think that you're embarrassed or you think that your clinician might be embarrassed? If I start with Nick.
Just unmuting myself there. I think it's difficult to have a blanket answer for that because everybody comes from a different angle and did a different journey. I guess this webinar hopefully will start that for some clinicians and for some patients as well, and realise that actually as a clinicians, GP, patient, physio, therapist, nurse, that we're all open to talking about this, and like Chris says, we're pretty good at keeping a poker face. So patients ask us some much more unusual stuff than anything about sex or intimacy, and we managed to keep a poker face. So we should be able to about this and then to discuss things. One of the things that we have in our chest clinic in Newcastle, and I'm not sure this is the right or a good answer really, but there is some resource from Asthma and Lung UK, which used to be the British Lung Foundation's renamed, and they've got a really helpful resource both online and printed about sex and breathlessness, and some of the kind of positional changes that Charlie talked about are there's kind of images, there's diagrams of what those positions look like and things to think about. But actually one of the things we have is just a poster in the waiting room that says, are you worried about sex or your relationship? Feel free to talk about it. Now, whether anybody actually looks at that, I don't know. It's not something that has been asked of me frequently in the non-ventilator clinics, but I think with home ventilation patients, we see them a bit more. There's a bit more going into people's homes. You get to know sorry, my earplug just dropped out. Get to know the patient and the family a little bit more. So I think sometimes that makes it easier to then say, actually, how are you? How's the relationship side of things? Oh, when did you guys let's get rid of the kids for the evening? That type of thing. So there's I don't think there's a good individual answer, but certainly making sure that as clinicians, we've got some of those resources, like Trudy says, ready, printed in the cupboard, ready to go, not necessarily even in the cupboards. GP surgeries will have walls and walls of information about, cholesterol and eating one of your 5 a day. So making sure that on that kind of plethora of information that's freely available is something about intimacy and sex and local services. And then building up a relationship where the patient or the carer or the family member, whoever it is, feels safe to broach intimacy with you and actually sometimes just asking. We ask about all sorts of things that are deeply personal to patients and deeply private all the time. So this shouldn't need to be anything different.
I would absolutely agree. I bring it up in every outpatient clinic that I have with patients after intensive care, because I think it's something that sometimes patients can feel worried about talking about. So if you broach the question first, and you can do it in a talk to me about your bladder and bowels, talk to me about how you're going to the loo, talk to me about how your relationship is, and then it breeds naturally from that, and it can be as much or as little as the patient needs and wants, and you can just say, leave it open for them. If you want to come and have a conversation, we're here. There's no question that you're going to ask that we haven't heard before, and if I don't know the answer, I'll find the answer for you. And I think it's so, as you said, Chris, it's okay not to know all the answers, because you're going to be dealing with people who've got all kinds of life experience and will be trying and doing all kinds of different things. So you might not know all the answers, but you can find somebody who will be able to help. Charlie, have you got any top tips?
Yeah, just exactly that, Kate. You've just got to create an environment and a space that it allows it to be, that conversation to be led. And I think for me, being a physio, I find it naturally comes into quality of life, hobbies, activities, and what are you struggling with? Is your breathlessness affecting anything like your hobbies or your activities of daily living, your intimacy? And I think you're tagging it on, but again, not making it solely about intimacy. You're just creating space, and then it allows anyone to kind of have that conversation there and then. But again, it just plants that seed of, okay, I might discuss that next time I see you. But also I find, particularly when I'm doing more advanced care planning conversations, and when I'm, talking to the partner who might be caring as well, just asking, and how are you doing? How are you making time to protect your relationship together? That's not necessarily, going into specifics, but you're just kind of, again, just allowing that to drip feed that kind of conversation. So that's kind of how I would go about it. And I find that a little bit more comfortable for me and for them, really.
Thank you. Trudy?
Yeah, I would agree that it's having that sex positive clinic, even if it's prior to any surgery that might cause them to be on a ventilator. So in advance of any treatment that might happen, as well as during and post treatment, is to say to patients, this, in my experience, it can have a huge impact on your relationship at any point. We're all trained to talk about that. Leaflets, little stickers, maybe scan codes that link them up to resources. One of the best places is in the toilets, not just in the waiting room. So on the back of the toilet door, on the mirrors, in the actual toilets, because people are a bit reluctant to walk over maybe and pick the leaflet up, but you could have leaflets on all sorts of things, and then a resource pack in an envelope that says all of the above is in this envelope. So somebody could be picking one up that's to do with something totally different if they took the whole resource pack. So there's that. And as I say, I think scanning a code is a great idea, because then nobody knows quite what resource that they were thinking they were going to have. But yeah, not just in the waiting rooms, but also in the clinic room. So where they're going to see the consultant or the specialist or the nurse, anything like that, so that it's everywhere around the clinic. But as Charlie said, make that part of everything else. So tag it in there, but high up on the list. So, is it affecting this, affecting that? What about intimacy? Are you struggling with that at any point? A lot of people do talk to me about that, or, and the patient might say, oh, it's the last thing I'm thinking of at the minute. Just say, I'm sure it is. So acknowledge that. Yeah, sure it is. But at any point, whenever you're ready, or you feel, you want to talk about that, we do have some training. We certainly have resources or referral pathway that we can pick that up. We wouldn't want you to not talk about it. They would be my big tips.